Zo, en dan is het voor mij natuurlijk een genoegen om u te vragen om uw werk voor te stellen. Ja.
Dank u. Mevrouw, geachte voorzitters, beste genodigden, allow me maybe to start by expressing my deep gratitude for the honor I've been given today. I think in part a personal honor, but absolutely also an honor for the whole team who has been and is working on these diseases today. So this is really teamwork, and I think it's important to stress this. We have been working on inflammatory bowel diseases, as Professor Himpus just said, for the past 20 years. And before I show you some images of what these diseases look like, I thought I would start by showing you first two images of what a normal bowel looks like. So to the left, you see how a normal small bowel looks like, and to the right, you see how a normal large bowel or colon looks like. We study inflammatory bowel diseases, and inflammatory bowel diseases is an umbrella for two main diseases. At one hand, you have ulcerative colitis, where you see a more superficial inflammation, and to the right, you see a typical example of Crohn's disease, where we see deep ulcerations along the gastrointestinal tract. Professor Himpus also told you these are diseases that start mostly at a young age, often between 15 and 25 years of age. But we also have children below the age of 10, more and more, I would say. These are diseases of life. These are chronic diseases. You don't die of these diseases. But I don't need to tell you, when you suffer daily from bloody diarrhea, not 2 times per day, 15, 20 times per day, going to the bathroom, incontinence, abdominal cramping pain, weight loss, and in children after often growth failure, they stop growing until the disease is diagnosed and until we can actually treat them. So these are really diseases with an important morbidity. Almost 1% of the population here in Western Europe and in North America at this moment suffer from inflammatory bowel disease. And the diseases are associated with a direct healthcare cost of between 4 to 6 billion euros per year. The disease was named, I like history, the disease was named after Dr. Burrell Crohn, who was a gastroenterologist and working at the Mount Sinai General Hospital in New York back in 1931, when he described the disease for the first time to the American Gastroenterology Association. And since, we have been calling it Crohn's disease, and later on came ulcerative colitis. At this moment, the largest prevalence is observed in North America as well as in Europe. And we think that about 1.3 million people in the US and Canada and 3 million people in Europe are suffering from these diseases. However, where we do see the disease booming most at this moment is in regions such as South Korea, Hong Kong, and in the large cities of Argentina and Brazil. We have seen the largest increase after the Second World War here in Western Europe and in North America, in the 70s, 80s, and 90s. And these regions are now seeing this booming, what we observed 50 years ago. So you can ask yourself the question, what is changing in these countries at this moment that triggers such a very rapid increase in inflammatory bowel disease? Well, I think you can all guess. This is a street view. I don't think we observe these days in our countries. We don't see this any longer in Western Europe. We don't see this in North America. And maybe we should move back just a little bit to this street view. Instead, we have become more clean. Hygiene became more and more important. I think we all became aware of the importance of washing hands. So I think more hygiene, becoming more clean, was certainly a good thing. But maybe we have become a little bit too clean at the moment. I think we have, to a certain extent, also lost our tolerance in early life towards certain things which are normal. We shouldn't become too clean. At the same time, next to this hygiene hypothesis, the food industry also changed. I think food needs to preserve longer. Food needs to look nicer. All kinds of additives, colorants are added in food, all the E. The texture of the food needs to be nicer, so all the emulsifiers that are added, we're adding a lot of things in our food chain, and a lot of these components, when you study them in the lab, they cause damage in the gut. So we do have evidence in the lab that not all of these substances are so healthy. And this is a very complicated scheme, but if I want to explain the real causes of inflammatory bowel disease, I cannot give you a simple scheme. There is not one single cause of the disease. It is a combination of a genetic susceptibility, so many individuals, many patients carry genetic risk factors, and then, as Professor Himpus just also said, at a certain moment in life, the bowel in a patient that develops Crohn's disease will start mounting an immune reaction towards the own gut. You have to realize that we have a kind of an army in our gut, and the army is constantly patrolling and make sure that we eat, we ingest food, and we live in close harmony with our food. We also live in close harmony with the bacteria in the gut. And this is normal. And this army is patrolling just in case there is an invader, there is a salmonella coming in, or there is a campylobacter coming in, then of course the army needs to react and make sure that this pathogen is killed and destroyed. So what is happening in patients with Crohn's disease is that their immune system, their army, starts to attack their own flora. We don't need to start an immune reaction against our own flora, and still it's happening. And again, this is triggered by some of the factors in the environment that I just explained you in the previous slide. And so I put it really simple because we don't have a cure yet. We cannot cure the disease. And so what we do instead is we simply, and it's simple really, we simply treat the inflammation. And of course, these diseases, these treatments such as anti-TNF and many other biologic agents are now so important drugs. But if you think of it, they simply treat the inflammation. And healing of the bowel, as you see here, is only observed in no more than a third of the patients. So we think we have now the best drugs and they work wonderful. And these are indeed our best drugs at this moment, but still we cannot help everybody. And this is, I think, one of the problems. Another problem is that despite the fact that we start healing the bowel, in that healing process, there is a lot of remodeling, there is scarring. And the scarring in patients with Crohn's disease, here you see a 3D image, the scarring process leads sometimes to stricturing, to stenosis. And this is, of course, the reason why many patients during their life need to have a part of their bowel resected. In fact, more than half to almost 3/4 of patients need bowel resections. It doesn't stop. You can say, why don't you take out the bowel which is sick? You can do that. The disease will come back in another part of the bowel, especially in Crohn's disease. So you cannot do that. And I apologize for the not as nice pictures, but another thing in Crohn's disease is that for unknown reasons, the inflammation in up to a third of the patients will present itself mainly around the perianal region. And I think you know that we still, in medicine, we cannot replace an anal sphincter. So patients do end up sometimes with a stoma. And if you have to give a stoma to somebody who's 18 years old or 20 years old, this is really a nightmare for these patients. So what are the challenges we face, both as clinicians as well as researchers? Well, when we see patients with IBD in the clinic, we will group them into Crohn's disease or ulcerative colitis. And in fact, this is really too simple. IBD, inflammatory bowel disease, is much more than simply Crohn's disease and ulcerative colitis. We have patients with small bowel disease, patients with large bowel disease. Some patients also have inflammation outside of the gut, for instance, on the skin, in the eyes, here in the mouth. So we do see a whole spectrum. This is not just one disease and one phenotype. And just grouping it into Crohn's and UC, we will never, I think, advance in finding novel and new treatments if we just keep it that simple. Another problem we have is that at diagnosis, all of these patients are called Crohn's disease. When we follow these patients over time, then we will see that after 5 to 10 years, only 25% will still have mild disease. The vast majority of patients will have evolved. I told you this scarring. So some patients will develop stenosis, stricturing, other patients will develop perforations leading to abscesses. So I cannot say at the time of diagnosis, we cannot say who will be the green patient who develops fistulas and who will be the light pink patient who remains very mild. If we would know that around the time of diagnosis, we could really adapt our treatment much better and maybe start more aggressive treatment in the groups to the right and more mild treatment in the patients to the left. So then this is to a certain extent what we do today. So for patients with very mild disease and very small ulcers, we will give them more mild medication. Industry has focused, I think in the past 15 to 20 years on the development of new drugs, not only in Crohn's disease and ulcerative colitis, also in arthritis, in psoriasis, in many of these chronic inflammatory diseases. And I think the introduction of biologic agents has really meant a revolution. And all of these agents are developed not for mild disease, but for moderate to severe disease, which is good. But now we're faced with a number of these drugs on the market, and we don't know which patient is the best candidate for which drug, or which patient will develop side effects to which drug. We cannot characterize, we cannot type. And so this is a little bit what we're doing in the lab. Again, I show you the picture, and I just told you that this is far too simple. What we want to do, and throughout my presentation, I just mentioned some of the people that are working on these specific sub-projects, but there are many more, of course. What we really want to do is characterize the patients in a more functional way. We want to know in patient A who's in front of me, how is this patient reacting to bacteria? How is the barrier in this patient? How is this scarring? Is this happening a lot, or is this not happening a lot? So we want a more functional characterization, and then based on these functional readouts, we want to choose our treatments. Likewise, we also want to have more molecular profiling using different levels of readouts, and I will show you, to guide us which patient will benefit most from which treatment, or which patient will develop side effects to which treatment. And this is what we want to develop eventually is the crucial index. So each patient will be typed, will be characterized on different levels, not only their genetics, how the genes are transcribed and translated into proteins, so in transcriptomics, proteomics, the barrier, and then a last part which I haven't addressed is the reaction to the endogenous microbiota. So we want to characterize patients much more on a functional level and then direct our therapies accordingly. So not just one treatment. I think we need to move much more into combination of treatments according to what is going wrong in which patient. And this is really not the same in every patient. So the last part, what I just showed you, the top three, dysbiotic score, ER stress, autophagy, are really things looking at the role of the microbiota, the flora. We know in certain mice and in certain rats that if you keep these animals germ-free, without any bacteria, they don't become sick, they don't develop colitis. If you move them to conventional housing where there are bacteria, they develop inflammation. So the rule is no bacteria, no IBD. And you can also do this in humans. More than 20, almost 30 years ago, Professor Rutgers in the lab in Leuven did an experiment where patients who had to have a part of their bowel resected because it was sick, and a stoma was put in place. So here you have from the stomach, the small bowel, the stools are collected in the bag through the stoma, and this part of the colon does not see any stools, no bacteria. Okay? What he then did was a very, I think, heroic experiment. The stools that were collected from the stoma bag were re-injected in this part, and see what happened. So this is before. Within days to weeks, when he injected the stools in the distal part, you saw small and larger ulcers appearing. So you can even mimic this in humans. If you divert the fecal stream, the inflammation will cool off. If you expose patients to the fecal, there's something in the fecal stream, in the stools, that is for these patients not good. So we try to further characterize this in the past years, and we identified a number of very different and very difficult bacteria. I think, to make a long story short, what indeed was seen is that patients with Crohn's disease and ulcerative colitis lack certain good bacteria, and good bacteria that produce, for instance, butyrate and other short-chain fatty acids. And patients, on the other hand, have too many bacteria that, and also their first-degree brothers, sisters, who are not yet sick, but they are at increased risk of getting the disease, they have more bacteria that will kill the mucin layer, the gel layer, which is a protective layer in our gut. So we start to see differences in bacteria between patients, between their unaffected first-degree family members, and between healthy controls. And this is what we're trying to work on also as a therapeutic opportunity. So what Kathleen also did is see, I told you, why don't you just take out a certain segment of the bowel which is sick? Well, if you do that and you follow up the patients after 6 months, then you see that almost 70% of patients will have again disease already 6 months after you have removed the sick part. The rest was all healthy. You follow them up in time. After 6 months, some remain fine. We don't know why certain patients remain healthy, and but 2/3 of patients again develop lesions. And Kathleen showed that here again, there were certain bacteria that were more present in patients who developed a recurrence. So all that information in the lab took us to two therapeutic opportunities. I think what we did is we took all the evidence from literature and the epidemiology, showing that these are diseases of Western countries. And so we developed a diet where we took all the good things and we left out all the bad things. So this was a almost complete vegetarian diet with a lot of fiber, almost no animal fat, no animal proteins, no sugars, no all these additives. And we first asked 30 people, mostly healthy people in the lab, to follow the diet for 1 month. And then, in fact, we asked 30 patients to follow the diet for 3 months. It was not easy to convince patients. It's another thing. You think everybody is interested in diet and how can I help as a patient to get my disease under control, until you show them what they need to do and how strict the diet is, and then all of a sudden they back up and they say, "Ooh, this is like really difficult." Now, in a nutshell, what we observed both in the healthy people but also in the patients, when they followed the diet for a few weeks to months, the richness, the bacterial richness in the stools was much higher. We all got a much more healthy microbiota. What we also observed is that there was less inflammation, and we measured this in the stools. And the interesting thing was, even in people who don't have Crohn's disease or colitis, there is a little bit of subclinical inflammation in the gut, and you can measure this with fecal calprotectin. And so these levels, even in healthy people, dropped very significantly. So you can really impact with your food and your diet on your own health. And another, I think, quite positive side effect was that most people lost 3 kilos on average by following the diet. And then the last thing we are almost to start in the next few weeks is a stool transplantation trial. More and more evidence is obtained now in literature that this could really help certain diseases. This is not a new thing. This is something that goes back as far as the very old Chinese literature, where they called it yellow soup, but also in the last century it was still used by Bedouins in the desert and they take stools from camels when they are sick to survive. So this is something which is over time being used, and now instead, in fact, it is only approved today for treating patients with Clostridium colitis. That's the only approved indication, but we are studying it now in a trial which will run over the different university hospitals. We call it the RESTORE trial. We did a pilot experiment already some years ago where we clearly observed, this is before, with all the white is inflammation, and if you give a stool transplantation, this is healthy stools from a brother, a sister, from somebody else who's healthy, then you can actually heal. You can transplant the flora and you can heal. What we did observe, and this is why the RESTORE trial is going to be done using super donors. So we did observe that some people have a more healthy flora than others, and it really matters from whom you get your transplantation. And this is why we are now, through the Flemish Gut Flora project that was conducted by Professor Raas at our university, we think we know who are super donors, how we can identify them in the lab. And we will use these super donors to transplant more than 100 patients with ulcerative colitis. And I think ultimately, and this is my last slide, so what we are doing now in the past years is from all our patients collect different samples, because these different samples give us different information. So we can look at the genes, we can look at the flora, we can look at how the genes are translated, and then we really want to profile patients much better. And I don't think that in the future we will treat, or we should be treating the diseases still by only one drug. I think we should use a combination, certainly look at diet, probably also some targeted microbiome modulation, add maybe something against inflammation in the beginning, and then see what goes wrong in that patient and in that patient, and target that patient in a much more individual manner. And so this is not easy to do, but we think it's feasible, and I think I have a whole team behind me who are helping me. So I think this is, well, in our opinion, really the future. With this, I would again like to thank the whole team, and many of them are here today. I also would like our local national funding, FWO, local funding from the KU Leuven, and the ERC, European funding. And I'm very grateful again that as of today I can also add the AstraZeneca Foundation and the Royal Academy. So thank you very much again.